Professor Knant, adjuvant treatment with an aromatase inhibitor is the treatment of choice for hormone receptor-positive breast cancer, including at the early stage. How has this impacted bone health in these patients, and what evidence is there for doctors to address bone integrity as part of the treatment landscape?
I think we are all very glad that endocrine treatments have evolved in recent years and decades, I should say. And basically, aromatase inhibitors are now part of the routine and the state of the art for virtually every breast cancer patient with hormone receptor-positive breast cancer. Results have improved both in the advanced setting as well as in the early setting. The main downside of this is that aromatase inhibitors affect bone health. Why is this? Because they, and that's our intention, reduce the circulating estrogen levels, and this negatively impacts on bone mineral density. In fact, for our low-risk breast cancer patients, the compromise of their bone health may even numerically be more important than the benefit they derive from our successful anti-cancer treatment. So these endocrine interventions, and this includes ovarian function suppression, even chemotherapy in younger patients, while being so excellent and helping us to increase cure rates, have the ability to compromise our patients' bone health, which is why it is so important that oncologists and physicians treating breast cancer around the world have the awareness of these issues. Fortunately, there is something that can be done about it. We can use bone-targeted treatments in order to stabilize bone health, in order to improve our patients' bone mineral density, and eventually prevent fractures, which is the ultimate goal of this treatment.
Would you briefly describe what you have done in the ABCSG studies?
In ABCSG, we have a long-term interest in bone health. That started when we investigated the use of the aminobisphosphonate zoledronic acid in premenopausal patients. That was in ABCSG 12. And we were able to demonstrate in these young patients that using the bisphosphonate in a 6-monthly schedule was able to abrogate the treatment-induced bone loss in terms of stabilization of the bone mineral density. It's a little bit more complex when it comes to fractures, because in these young patients, fortunately, fractures are rare events, and we were kind of struggling to demonstrate that we would ultimately also beneficially impact on the fracture rate. This, by the way, is true for all the studies with bisphosphonates. However, the better is the enemy of the good, and very fortunately, we now, since many years, have the monoclonal antibody, anti-rank ligand antibody denosumab available. And in ABCSG 18, we tested the adjuvant treatment with denosumab in a placebo-controlled fashion, phase 3 trial, more than 3,000 patients. And the primary endpoint of this study was fractures, in fact, clinical fractures. So that's the most relevant form of fractures our patients may suffer. And what we observed is actually two things. First, the overall incidence of cancer treatment-induced fractures in postmenopausal breast cancer patients receiving aromatase inhibitors may have been underestimated so far, heavily underestimated. We look at fracture rates of, let's say, 15 to 20% within 5 to 7 years. Second important observation we made in that trial is that The adjuvant use of denosumab in the bone protection dose, which is 60 milligrams every 6 months, basically cuts the frequency of fractures in half. So that's a quite dramatic decrease in this major side effect. Maybe a third issue important to note is the tolerability. This treatment is almost perfectly safe. In this double-blind, placebo-controlled trial, we were literally not able to identify any significant differences between the antibody group and the placebo group.
Various global guidelines consider treating bone metastases in breast cancer with anti-resorptives as standard of care to prevent skeletal-related events and to maintain quality of life. Yet in Asia, treatment is often symptomatic rather than preventive. Is there a need to treat earlier, and what can doctors or patients do?
This is a very interesting observation that we have such variation in the treatment patterns between different regions in the world. Fortunately, I've had the opportunity to visit many centers and continents, and it's very, very true what you said, that unfortunately in Asia there is a tendency to treat only the symptoms but not the disease. And patients actually have the tendency to say, okay, the pain is gone, now I don't have to take my treatment any longer. This is a misunderstanding of how bone disease works, particularly with patients with breast cancer who have a rather significant likelihood to develop bone metastases. It is important to understand that what the goal of our treatment is. The actual goal of our treatment in treating bone metastases is to prevent what we call skeletal-related events. This is heavy pain, this is the need for surgery, for bone fractures, the need for radiotherapy, all these things. And it has been well demonstrated now since more than 2 decades with all kinds of bone-targeted therapies that we need to start this early. We need to continue doing this. It's also important not stop at the first fracture. If one happens, it's important to positively impact on the bone physiology even after the first fracture, because subsequent fractures are also beneficially prevented or treated or at least reduced numerically. So waiting for symptoms to occur or immediately stopping treatment after symptoms have been resolved is not the optimal way to apply this knowledge to the benefit of our patients.
What are the major barriers to drug adherence in the bone-targeting agents, and does adherence affect outcomes?
I think we are basically, in many aspects of oncology, by our success, we are learning that adherence of patients to treatments is not a given. Because very fortunately, we have been able to increase survival times in metastatic breast cancer. We have been able to increase cure rates dramatically in recent decades, but that also means that when the symptoms go away, the threat may not be perceived as being present longer than patients' discipline or motivation or, let's say, awareness about the importance of continuing treatment poses an issue. And I believe it's very important for us as doctors to learn that communication about these things is needed. Patients need to understand why sustainable benefits are best reached by optimal drug adherence. This does not necessarily mean that we cannot adapt, and not always treatment forever is the way to go. But in principle, adhering to the therapy strategies we have decided on is a very important thing. Clearly, there's a number of challenges with this. side effects, and tolerability is one of them. And we have to be very careful not to overestimate side effects. In some regions of the world, this is not Asia, for example, patients decide about their treatments almost only or solely based on side effects, which I think is not the optimal way to use these treatments. We need to balance the efficacy with the burden of tolerability issues. And in fact, in experienced centers, most side effects can either be prevented completely or dealt with in a very successful way. And it's also an important task for us as physicians and nurses to build the trust with our patients, that they tell us about the side effects, they tell us that they are considering stopping a treatment, and then we can potentially offer something reasonable to them. Clearly, we have to admit that some of our innovative drugs are also, not particularly cheap. So financial toxicity can also be an aspect together with respect to treatment adherence.
What affects your treatment decision when choosing an antiresorptive in your patients?
I guess the antiresorptive treatments are aiming at stabilizing and maintaining quality of life. Also prolonging life, because we know, for example, when we successfully treat bony metastases, our patients will also live longer. But in principle, this is targeted at stabilizing our patients' quality of life. Thus, it is extremely important that our treatment by themselves are not negatively impacting our patients' quality of life. So, easiness of use, absence of awkward tolerability issues, these are main denominators in our treatment decisions. I think, in addition to the better efficacy that has been demonstrated in clinical trials, for example, for anti-rank ligand inhibition as compared to bisphosphonates, is that when you have sub-Q injection rather than an infusion, when you don't have to think so much about potential renal toxicity and all these things, these are major arguments why in most environments around the globe denosumab has substituted bisphosphonates as the first-line treatment of choice.
There remains a concern amongst physicians regarding osteonecrosis of the jaw, ONJ, with the antiresorptives. What is your opinion on this, and how do you minimize the risk of ONJ in clinical practice?
Osteonecrosis of the jaw is an issue, but I think it needs to be put in perspective. Based on, let's say, some miscommunications early when we detected this rare condition as a scientific community, it has been almost something like a hype around this, together with antiresorptive agents. For scientific completeness, we have to say that this rare condition does not only occur after antiresorptive treatment, it also occurs with chemotherapy. It rarely, but still occurs with anti-VEGF treatments. And it's a condition we do not perfectly understand, because it obviously has to do with the partial pressure in some of our particularly sensitive areas in the jawbone. It is important to note that overall this condition is very rare. So we are speaking about, let's say, 1 to 2% in heavy treatment environments. For example, in early cancer patients, when we use antiresorptive drugs, such as denosumab in the bone protecting drugs, it's virtually not existent. In the ABCSG 18 trial, we have proactively looked for this condition. Actually, we hired a specialized medical officer just looking through all the databases and the charts and trying to identify candidate cases. And we now look at more than 12,000 treatment years in that randomized clinical trials. And eventually, we were not able to identify a single confirmed case at the 6-monthly dose. Clearly, this is different used with phosphonates or denosumab in a 4-weekly interval, as it should be done for the treatment of bone metastases. However, also minimize the danger that the patient would develop ONJ. First, start with a dental status, do repair work if necessary. Second, patients need to be advised and educated about dental hygiene. There's very interesting observations that actinomyces is present in most ONJ cases. And when you look around the world, you will see differential prevalences of the condition based also correlated on the general dental health status of patients in a given healthcare environment. So, communication, education of patients, awareness among physicians, and if the condition or a candidate condition occurs, then there is a very clear-cut set of recommendations what should be done. Most dental problems that actually occur turn out not to be a real ONJ, and even if osteonecrosis of the jaw is developing, in most situations it can be rather easily handled and heals quickly. So I think while we need to be aware of this, we need to educate our colleagues around the world about this. Eventually, this is not an argument to withhold the benefits of anti-resorptive treatment from our patients.
Based on your knowledge on the available data, how would you encourage other doctors to address bone integrity throughout the continuum of breast cancer?
I think that we, in the field of oncology, and particularly in breast oncology, but also probably our colleagues in the field of prostate cancer, we have learned that issues are very important for our patients. This is true for early cancer patients, when with our otherwise successful anti-cancer treatments, we have a tendency to compromise bone health. And with anti-resorptive treatments, such as denosumab, we can do something against this. We can prevent fractures, we can reduce the negative impact on bone health. In the advanced cancer setting, obviously for quite a number of malignancies, bone metastases pose a major problem. And the quality of life, but also the outcome and the survival outlook of our patients heavily depends on how well do we deal with bone-related issues. So I think 3 decades ago, oncologists didn't know too much about bone physiology, about the vicious cycle, the interaction between osteoclasts and tumor cells, and how all these things work. Fortunately, this has changed. And I think it is of great benefit for our cancer patients if physicians are aware of the importance of bone health, maintaining, stabilizing, and improving bone health for our cancer patients throughout the treatment continuum.